Welcome to the MamasteFit Podcast. In this episode, we're interviewing Hayley Kava, who is a pelvic floor physical therapist, and we're going to be talking all about perineal lacerations or tears, what you can expect if you do have a tear, what are some things that we can do to prevent having a tear, and then next week we're going to dive into instrument-assisted delivery, things that may impact your perineal health after birth, and then also what you can do to recover from birth. So this will be a two-part series. This week, we're talking all about what are tears, how can we possibly prevent them, and next week, we're going to dive into what are some things that may make your tears more severe, in addition to how can we heal from our perineal tears. Welcome to the MamasteFit Podcast. This is Gina, perinatal fitness trainer and birth doula.
And I'm Roxanne, labor and delivery nurse and student midwife.
And this is the MamasteFit Podcast, where we empower you on your prenatal fitness, birth, and postpartum return to fitness journey.
Our podcast shares how to move throughout your pregnancy to stay strong and comfortable, because pain is not a requirement of pregnancy. Understand the science of birth and how to approach recovery after birth.
We share our personal experience as mothers navigating this stage in our lives, plus our professional expertise as birth workers and fitness professionals.
Our goal is to help you feel confident as you navigate the perinatal timeframe for an empowering pregnancy, positive birth, and postpartum journey.
We are glad to have you with us on this journey and that you have chosen us to support you. Welcome to the MamasteFit Podcast. Hayley, we're really excited to have you here on the podcast again. If you are an avid listener of our podcast, you'll know that Hayley was previously on the podcast, I think like episode 9, where we talk all about preparing your pelvic floor for birth. Hayley is one of our favorite pelvic floor PTs. You can work with her virtually if you don't have an in-person PT nearby. But thanks so much for being here again, Hayley.
Yeah, thanks for having me. I'm excited to be here.
Can you just introduce yourself to our listeners again in case some of our listeners are not familiar with you?
Yeah, absolutely. So my name's Hayley. I am a pelvic floor physical therapist, currently based out of Kansas City, Missouri, but also a military family. And so we have lived in Minnesota and North Carolina, and I am connected with MamasteFit via living in North Carolina with them and working out of the MamasteFit gym. We will be back there this summer, so I can't wait. I have 2 little boys, a 6-year-old and a 3-year-old, and they are definitely part of the reason why I dove deep into this work, because that's a big it was a big shift, and seeing how recovery from birth and pregnancy and all of the things that can fall out from giving birth weren't supported appropriately made me want to get into this. So that's why I'm here.
I feel like that's how a lot of folks enter this like perineal support career field. Is they gave birth, they had a pregnancy, they're postpartum, and they realized like the lack of resources that were available to them. And I feel like there's so much more now with folks that are supporting the perineal time frame with like perinatal fitness trainers. And I feel like there's even more pelvic floor PTs. And I think like the explosion of like TikTok and social media where folks are sharing so much information is also like really helping folks like recognize that there's a lot of resources out there for them. Because I know I got into this because of my own birth and pregnancy.
Yeah, I remember when I was pregnant with my first, someone had mentioned the term doula to me. And I was like, oh, what's that? And then looked it up and couldn't find anyone kind of local online. So I was like, oh, well, I'll be all right. And I was not all right. And then learned what a doula was and all of the good stuff that they do and way more. So that tells me, I guess, how far things have come.
I didn't know what a doula was either my first birth. My husband was the one who was like, we should hire a doula. And I'm like, what is that? Which is pretty funny.
Yeah.
So let's get into it. So first, we're going to talk about what are the different types of tears that could happen if you have a vaginal birth. 70% of us are going to have a vaginal birth. And so there's going to be a lot of us that may or may not have some sort of perineal trauma. But if you had a vaginal birth, there's still a lot that's going on with your pelvic floor, which would obviously require a lot of healing. But Roxanne, could you talk about how many of us can probably expect to have any sort of tear and what are the different types of tears that someone may experience? And this is not to scare all of you. It's just to help you understand like what might be going on down there. And then we're going to discuss the recovery and how to hopefully limit some of that tearing as well. So yes, about 70% of us are going to have vaginal birth. And within that 70%, 85% of those people are going to have some degree of perineal laceration. People who have an intact perineum, so there's no tearing, about 10% of those are people who this is their first vaginal birth. And then 30% of those are about people who've had babies before vaginally. So multipitous or nulliparous is the common term used in medical terminology. Increased rates of having an intact perineum are if you had a community birth or a midwife. This had led to more people having an intact perineum versus hospital birth. Can you explain what community birth means, just in case folks don't understand that phrase? Community birth is a birth that happens outside of the hospital, usually attended by midwives. So it could be at home, a freestanding birth center, or it could have been like a birth center that's a part of a hospital, but like its own unit. Okay. Because it's not like your neighbor is helping you give birth, like community. You're not in the hospital. Yeah, it's out in the community versus hospital. Some people will just call it out of hospital, but that like inherently creates this understanding that hospital is the expectation. And when you deliver outside of that expectation, it's outside of a hospital versus, back in the early days, I don't remember when it changed. I can't remember. Everyone delivered at home. And so that was just considered the normal. And now everyone delivers in hospitals. Okay, so the different types of vaginal tears. So there's 4 different degrees, and Hayley, feel free to jump in at any point. A first degree tear is just a tear into like the superficial skin of the like the vagina. The perineum is the skin between the vaginal opening and the rectum, like that skin between. This is where most vaginal tears occur during birth, but there are other places that you can tear as well. But we're just going to talk about the perineum mostly because that's the most commonly talked about and the most like well documented of different things that we can do for them. But there are 4 degrees. The first one is just into the superficial skin of the like vaginal mucosa. It's almost like you like scraped your knee or like cut your knee. It's like not into muscle or anything. Usually it can kind of come together on its own, sometimes without even repairing it. And sometimes, depending on if that bleeding is pretty heavy, you might need a little bit of suturing. The next degree is a second degree. And as we've learned, there are different degrees within that second degree because it's through the superficial skin as well as into the perineal muscles. And it could vary on how deep into that perineal muscles it goes. And that can depend on your like long-term function as well. So I myself had a second degree, and I find that like my recovery after that birth was a lot different compared to my subsequent births where I only had a very light first degree, if you would call that at all, because of that muscle involvement. It took a while for me to kind of heal from that muscle involvement, but you could have just like the superficial layers of the muscle, or it could go deeper because the next one is a third degree. And the difference between a second and a third degree laceration is the involvement of the anal sphincter. A third degree is all the way through the superficial skin, through the pelvic floor, as well as into the anal sphincter. And then the last one is a fourth degree, and this is where 2 holes are now one. So it is through the skin, the superficial skin, the pelvic floor muscles, and all the way through that anal sphincter. Obviously, that is not ideal, as well as a third degree is not ideal because of that involvement of the anal sphincter that could lead to some long-term pelvic floor dysfunction, as well as maybe some pelvic floor rehab is needed a lot more with those ones. So Hayley, obviously you probably see third and fourth degree rehabs a little bit more because those ones usually are actually referred to pelvic floor PT versus some first degrees or second degrees are not always referred out for pelvic floor therapy. If you want to mention some about that.
Yeah. So what we know about, first and second degree tears is that tissue, that perineal tissue is so heavily vascularized. It's almost like it's designed to expand and tear during birth. And so what we see is that in general, people tend to do better in their recoveries with those first and second degree tears. That's not to say that they can't have their own challenges and don't deserve support in their recovery. But really where we see people struggle a lot is with those third and fourth degree tears, because they're most likely not only further down into the anal sphincter. So they're going to impact our urinary incontinence and our fecal incontinence, right? Like having poop accidents and pee accidents are a little bit more difficult to manage, but they often tend to go a little bit deeper into those deeper layers of pelvic floor muscles. So we not only have this sort of these superficial layers, and our anal sphincter being a more superficial pelvic floor muscle, we have deeper levels of that sort of bowl of pelvic floor. And so the further that tear goes, the more likely it's also going to be impacting those deeper layers of pelvic floor muscles. And then the nerves and the blood supply of that pelvic floor that help our brain and our body figure out how to control our pee and poop and all of those types of things. I think the other thing that I'll add to those other types is that I think a lot of people are alarmed sometimes when their tears. I think we always picture those tears going down, but it's not uncommon for those tears to go sort of into vaginal wall, so kind of up inside, also up to the urethra, so where pee comes out, and even up into the clitoris. And so I have definitely had a number of clients with periclitoral tears and periurethral tears that really struggle because those can be incredibly sensitive areas and areas that have a lot of nerves and have a lot of blood supply and have their own unique challenges in the recovery process as well.
So fortunately, third and fourth degree tears are not incredibly common, which is, we can all be really thankful for that. I think it's like less than like 7 or 5% of births, like maybe even lower than that, especially if it's like a subsequent vaginal birth for you. Like your risk of having a more severe tear does decrease the more babies you push out of your vagina, which, is good. So for me, with my first, I had an episiotomy, and we'll talk about instrument-assisted deliveries and kind of how that recovery may be different than having a natural tear in your perineum. But for my second, I had like a very superficial first degree where I had like one tiny stitch. And then my third, I had an intact perineum. And so each birth my tears got less. And that seems to be the trend with a lot of my clients as well. Like the more babies you have, the less likely or the less severe the tears are going to be as well. But I would say probably the most common that I see with my doula clients is that like second degree type of tear. So Hayley, could you talk a little bit more about like what you've learned about how even with like a second degree, there are different levels to like the severity of a second degree tear that could impact someone's healing and recovery really differently if they had like not like an almost second degree, maybe almost a first versus like a second that's almost a third degree tear.
Yeah, I think something that's really common in that early postpartum period that can sometimes set our pelvic floor up for a bit of challenges down the road is how uncomfortable and how sensitive that whole area is. And that could be, depending on the, grade, but also swelling and inflammation and things that just naturally occur because of having a vaginal birth. And so I find when people tend to be more swollen and more have more pain or the stitches are kind of irritated, is that sometimes we can end up with some urinary retention where we're not able to relax to pee, or when we do pee, it burns a lot. And so we're not completely emptying our bladder. So that's where peri bottles come in really, really handy, and getting warm water and sort of spraying it over everything so that we're not, those muscles aren't kind of tensing up in anticipation of the pain of that peeing. The other thing so then the problem with that is that if we end up in a cycle of urinary retention, it does increase our risks of urinary incontinence and other bladder control issues down the road. The other thing is that if it's really painful and we have more stitches and more into that perineal body, when we go to have a poo after giving birth, and when we have a bowel movement in general, our perineum does need to bulge a little bit in order to relax enough to let a bowel movement out. And so if you can imagine you have stitches in here and it's really sore and irritated, we might be a little less willing to relax in the way that we need to in order to have a bowel movement. So we can end up constipated. Then we have this big, hard, difficult to pass stool, and that can create more tension on our healing tissues, and that can delay some of that early healing response that we want to have happen. And so using something, or using like our hand to splint the perineum for bowel movements, splinting for coughs and sneezes, splinting when we're getting up, even wearing that compressive support, can all be some really simple things that can help support that early healing process.
When I reflect on my first birth, where I had a lot of stitches and compared to my second, and I didn't have any for my third, like that first poop was terrifying. But that makes a lot of sense. Like if my perineum could not move very well because there was a lot of stitches, and I was probably also guarding in a way as well, because I'm like, there's a lot just happened down there. Like I remember like kind of just like hanging on to the wall and being like, oh God. But for my next two, I don't remember that same like traumatic poop experience like after birth. And I don't know if it's because like my pelvic floor was able to move, my perineum was able to move a little bit more easily because I didn't have the same type of stitches. I didn't have that same level of like trauma to the pelvic floor. But do you feel like was it still traumatic for you all the times, Roxanne? Every time.
But I also have prolapse. Like I have a rectocele, so like it's a little bit more uncomfortable just in general, I feel like, to go to poop. Because it's like I always, even when I'm like have zero symptoms, I'll always have like, hey, I might still need to go, but like I don't actually. Like that's just like that feeling that I have every time, like 90% of the time. So when I'm like postpartum, especially, I'm just like, I don't want to like have to do this again. So I hope I'm done, but I also don't think I'm done.
Yeah.
It doesn't hurt. It's just scary. Yeah. It's never uncomfortable. It's always scary.
Yeah. We know like a couple bad episodes of constipation can really exacerbate a rectocele and can really exacerbate or make it challenging for that pelvic floor to heal in that early period. If we're constantly like loading it up with a ton of stool, it's a lot of extra weight on those pelvic floor muscles.
Yeah, colace.
And so really, really being able to take care of that perineum in that way. I think people post C-section get a lot of advice. Hopefully they're getting a lot of advice about, supporting their incision for bowel movements, or supporting their incision for moving, or, if they had cough or sneeze. But I think for a healing perineal scar or, injury, so maybe we're sitting on, I don't love donuts, but sitting on like your boppy pillow, sitting on, I call it railroad sitting sometimes, where we're putting two towels kind of under those sitting bones, making sure the way we're sitting is supportive. So we're maybe not dumping back and increasing the pressure. We're maybe getting that chance to like fully lay down and let that tissue heal and rest and recover in those early days is really valuable.
So Roxanne, what could someone expect for the repair of a vaginal tear if they had an unmedicated birth, and then if they had an epidural birth? Like what could they expect their provider to do?
So we'll start with unmedicated. If you do not have an epidural in place and you need a laceration repair, or even an episiotomy repair, any sort of repair, they're going to use lidocaine to numb the area so that they can then repair it if it's necessary. The lidocaine doesn't feel great as they insert it and administer it, because it is similar to like when you go to the dentist, where it's like that poke, and then you might feel a little bit of like the burning. Even if you had an epidural, that is what the lidocaine injection, where it's like a sting and then a burn. Similar, but it's in a little bit more of a sensitive area that you just birthed a human out of. So it's a little bit more sensitive when they administer it. Some people, like I noticed it, but it didn't bother me crazy amounts. Other people, they're like crawling out of the bed, like, please get away from me. And it can just be dependent on like how it tore, like where the nerve endings are that like they're trying to administer the lidocaine at are. usually goes away if you count to 10. The numbness starts to take effect, and then they'll repair it. There are different layers within the tissue of the perineum, though, that sometimes, depending on where you tore and where they need to place a suture to like get it together, it may not be fully numb, or like you might feel it a little bit more. But most of the time you should just feel tugging and like maybe some pressure and like pulling, but it shouldn't be like sharp and painful. If you feel sharp and painful, letting your provider know that, hey, I felt that was really sharp, then they can maybe adjust the lidocaine, or potentially it's just unfortunately a spot that they can't get. They can try and like wait for it to numb up, but it's kind of dependent up to your provider and you and whether or not it actually would be helpful.
You can also use nitrous oxide if your birth location has it. If you have an unmedicated repair, which you'll still have the local anesthetic, but the nitrous can help you kind of relax with it, especially if it's an area that the lidocaine just doesn't quite get to. Like I think some labial tears, like the lidocaine just doesn't help for it. And so the nitrous oxide, if your birth location has it, can be a really great option as well for repair.
Same if you had, like, not many I've seen, if you have a periurethral or a clitoral tear, any like towards the top need a ton of sutures, but just in case, if you do need one towards the top, there are a ton of nerve endings, and sometimes that lidocaine just can't get it all. So those ones can be a lot more uncomfortable. So that nitrous oxide can be really beneficial if it is available. There are also things like pudendal nerve blocks. I've never seen one, but that is an option that kind of like numbs that whole area to kind of help as well. Sometimes they'll do that if it is like a really severe 3rd or 4th degree and they did not have an epidural. They might be able to place that for that repair because, again, lidocaine for a 3rd and 4th degree tear I don't find will be as helpful, but sometimes it is.
Yeah, I remember.
If you have an epidural, though, any repair, like you shouldn't feel anything because that epidural is like you're still numb from the waist down. So they'll keep that on for the length of the repair until the repair is done. And that's when they'll turn your epidural off to make sure that, again, your sensation doesn't come back while they're suturing your vagina together.
Yeah, with my second, I just had a small tear. And she's like, I think 1 or 2 stitches will do it. And I was like, okay. And she's like, I think I'll only have to, it'll be quick. So if I give you lidocaine, it'll probably hurt just as much for me to give you the lidocaine as it will be to just stitch it. And I was like, like, okay, go for it.
No.
Give it a try. And she starts to do the first stitch. And I was like, absolutely not.
Oh, God.
I feel like in theory that might make sense. But with a suture, you have to go through the skin at least twice.
Yeah, I was like
each
and
side.
Pull it through. Like, yeah, not
Like
like a
lidocaine,
lidocaine.
it's just one injection and then they push. Like, I feel like that's not as bad.
Yeah.
And the needle is like way smaller than the needle that they're using to suture you with.
Yeah, no, I was like, I looked at her, I was like, you're crazy if you think you're going to do that, like, keep
More than once.
going.
Like 4 more times.
Like, yeah, if you have to do 2 of those, give me the lidocaine, I'll wait.
Oh, gosh. No. No.
So that was...
For some of the 3rd and 4th degree tears, I have heard some OBs say like, hey, if I am having a hard time doing this, like we're going to have to go down to the OR to do the repair because I need a little bit more like equipment or lighting. Like what is the reason for needing to go to the OR?
Usually it's the lighting. Because like labor rooms have that like bright light. So depending on like how it tore, just because like it's not going to be a surgical incision where it's like a straight line that they just have to put together. There's usually like zigzags, for lack of a better word, just like the way our tissues naturally tear. It's not like a straight line. So sometimes depending on like how it tore all the way down, they might need more lighting. And like you think the lights in the labor room are really bright and you're like, you could see everything. They're like, it's so bright. I'm being blinded. You like go into an OR. It's like twice, like 3 times as bright. And as they have like a million more lights to be like a spotlight on your vagina to be able to see a lot better. So that's usually, and then it might be like tool dependent. They might need more than just the tools that come in the delivery kit. So sometimes people will have a 3rd and 4th degree kit in hospitals that is only like all of the things that you would need for a 3rd and 4th degree tear, or even like if there's a cervical laceration. So the cervix is vascular, and even though it's like technically dilated, it hasn't like disappeared fully. After the baby's there, it could have, if it wasn't fully dilated especially, it could have tore. And sometimes they have to repair the cervix as well. So there is like all of these tools that they would need for all of these different more severe tears in a little kit that they'll bring in. But if they don't have that kit, sometimes they'll also have to go to the OR for those specific things. Some providers, again, they do an amazing job at the bedside, and then other ones, depending on the degree and then their experience, might need to go to the OR for a better picture.
Let's take a break from this week's episode to talk about our podcast sponsor, Needed. Needed is a nutrition company that focuses on optimal nourishment for the perinatal timeframe and is a brand that Roxanne and I have used both during our pregnancies and in our postpartum to help supplement our nutrition. One thing that I've noticed when I'm at births is if somebody has a low animal protein diet throughout their pregnancy, such as they're a vegan or a vegetarian, if they do have a vaginal tear or a perineal laceration, it can sometimes be really hard for the provider to do the repair because the tissue is very friable, or it's really hard for them to maintain that tissue integrity as they're trying to suture it back together. And so something that you can add into your diet if you are a vegan or vegetarian, or if you do eat animal protein, is you can add in a collagen source. Now, there's tons of food-based collagen sources that you can have, such as bone broth or pulled pork or slow-cooked meats. But a collagen supplement can also be a really great option, and is something that Roxanne and I have used during both of our pregnancies, and the one that we love is obviously from Needed.
Obviously. So Needed is very intentional with all of their sourcing as well as all of the ingredients that they use in their products, especially their collagen protein. It is a hydrolyzed collagen, so it is easily absorbed as well as really dissolves actually easily in a lot of the things that we add it to. So we added it to chia seed pudding, my morning coffee. You can add it to orange juice in the morning, pretty much many things I can add that collagen protein, and it dissolves well and doesn't leave a taste. So it doesn't alter the taste of the foods that I'm eating, which I have found in other collagens that it does, and it affects like how much I'm actually going to use as collagen if I can taste this like weird aftertaste to it.
Our protein needs during pregnancy also increases, so adding a collagen supplement can be incredibly beneficial to support your nutritional needs throughout your entire pregnancy. If you want to check out Needed, you can go to thisisneeded.com and use our code MamastePod to get 20% off your first order or 3 months of subscription. I have seen some providers like call in other providers if it was like a tear that they felt was a little bit out of their skill level, which I do appreciate. To be like, hey,
you want that.
calling in this other midwife, I'm calling in the OB to take a look at this because I want to make sure that we do a really good job because this is really going to impact your health for a really long time. And so I always appreciate when the provider does that. So if you do have a tear that is a little like unique, like they may call in some additional assistance. So just be aware that that may happen, but they should communicate it to you before like a bunch of people just bust in. But I would say roughly with like a 2nd degree tear, I usually see like after baby's born, about an hour-ish after you're kind of snuggled up in your bed with your baby and the repair is complete at that point. And that's being very generous with the time. But usually for my doula clients that have 2nd degree tears, I'm usually around for about another hour before like they're all snuggled up and cleaned up in their bed and everything.
Yeah, and I would say from like a pelvic floor standpoint, if I had a client with a 3rd or 4th degree tear, I would, or if I was like there, not that I do birth work, but I would advocate for that OR repair, namely because things like rectovaginal fistulas can happen. And so the full assessment of the integrity of that vaginal wall, that rectal position, because that's really the biggest risk, not the biggest, but a big risk with those high degree deeper tears is that we don't want your poop to end up coming through your vaginal opening. It's a little bit of an infection risk and really big life challenges.
Can you explain what a rectovaginal fistula is?
Yeah, so it's when there's a tear between the rectum and the vaginal opening. So your stool, which comes down the rectum, would break through a hole through the rectum and make its way into the vaginal canal because that tear went through that whole area. And it is not common. So as rare as 3s and 4s tears are, to develop a fistula would even be rarer than that. But that when they're doing those more thorough investigations of 3s and 4s, they're just making sure that that's not the case. And
that's why a lot of midwives won't do 3rd and 4th degree tears, because one, they don't see them very often, and two, because that's a pretty important area to be repaired very well.
And I would say, all vulvas look different after we give birth. And I have seen people with 4th degree tears where you could barely tell, right? So I think it's important to remember that this area of our body is incredibly capable of doing incredible healing. That being said, if you have had a very high degree tear, it's not, again, your OBGYN is also not a plastic surgeon. And so they're doing this repair to just get those ends of that tissue coming together. And so if things aren't healing the way you'd like, it's okay to reinvestigate that at a later time down the road, and see if there's other things that need to be done.
It's like a vaginoplasty. But I know people, like, during pregnancy, like, you were in a low estrogen state already where, like, that impairs your healing, which you think would be opposite. You think you'd be like freaking Wolverine expert healer, but we're not. So I know people who have had like more in serious tears, and then like 6 months to a year later, when they have a more like a higher level of estrogen within their bodies, they'll go back and get them redone, because like the tissue, I mean, it's all swollen. You just pushed a baby out. It's like, it looks different than when it's like calmed down, for lack of a better word, so that they can make it like kind of line up a little bit better later.
Exactly.
Absolutely.
Even for like lower grade tears, I always tell my clients, there might be a bit of, as it's healing, there might be a bit of itchiness, there might be a bit of irritation, but it shouldn't be extraordinarily painful beyond those first couple of days. And if it's then still extraordinarily painful, go get it checked out. Because sometimes there are little procedures they can do in office. Maybe a stitch is doing something funky and they can fix it, or there's some granulation tissue, just meaning that the scar tissue is growing a little bigger than it should, and they can cauterize that with silver nitrate in the office. And so there is lots of there's no need to suffer unnecessarily in that period, and to definitely not wait to that 6-week appointment if something's really bothering you.
I had some granulation tissue after my first birth, so my 2nd degree tear, and it was like probably a week or two, and I was like, it's still kind of uncomfortable. I feel like it should be better by now. And I think I made an appointment, and they're like, oh yeah, like they just prescribed me estrogen cream to place on top of it, and that healed it just fine. And they're like, we can cauterize it with the silver nitrate, but that is not comfortable for a lot of people. So if we can avoid that, that'd be great. And I was like, I am down with just putting cream on me versus cauterizing some tissue.
Yeah, topical vaginal estrogen is magical. And the more we're learning about it, because more and more research keeps coming out about it and about the wonders of it, is that we're wondering if maybe it should be sort of a part of the standard treatment of a postpartum vulva, because whether you had a cesarean or a vaginal birth, that postpartum vaginal perineal tissue, vulvar tissue, the estrogen state is so low. And so if you're having pain with sex, you're having pelvic floor issues, you're having any of that topical vaginal estrogen can be a game changer.
Thank you so much for listening to part 1 of our 2-part series all about perineal tears, what we can do to prevent perineal tears, what we can expect if we do have a perineal tear, and then how we can recover the pelvic floor and the perineum after birth. Next week, we're going to be talking all about what we can do if we have an operative vaginal delivery, which means we have a vacuum, forceps, or episiotomy, how those may impact our pelvic floor, and things to consider when it comes to this birth and for future births. We're also going to be talking with Hayley about what we can do after birth to help protect our pelvic floor, to help heal our perineum, and any sort of tears that you may have had. So be sure to tune in next week if you want to continue to learn about what is happening to your vagina and what you can do to heal it after birth.
If you want to learn more from us and you're pregnant, we have a prenatal fitness program as well as childbirth education. If you're in the postpartum, we have an early postpartum program that is what you can do for the first 4 to 6 weeks postpartum, as well as an education course of what to expect in the postpartum and newborn care that comes with infant CPR and infant massage. And we also obviously have postpartum fitness courses that can help you return to fitness, whether it's running, weightlifting, or just general fitness. And if you're a professional and you want to learn more from us, we have our birth workers course and a prenatal postpartum fitness trainer course. And just as a thank you for listening to this entire episode, you can use code STORY10 to get 10% off of any of our offerings.
This podcast is sponsored by Needed, which is a nutrition company that's focused on optimal nourishment for the perinatal timeframe. It's a brand that Roxanne and I have both used throughout our pregnancies and our postpartums, and so we trust them and we recommend them to you as well. If you would like to check them out, you can check them out at thisisneeded.com and use code MamastePod to get 20% off your first order or 3 months of subscription.